Odontogenic tumors. We know what is a tumor. Tumor is nothing but a neoplasm which arises because of abnormal growth of the tissue. Why does this neoplasia arises? It may be because of either the genetic mutation or the cells undergo some dysplastic or metaplastic change, leading to proliferation of the tissues of that specific region. We know the neoplasms or tumors, they may be either the benign or the malignant one. Benign are basically the non-cancerous growths. The term tumor should not be understood as a cancer always, because the benign tumors are non-cancerous, whereas the malignant tumors, because of their tendency to infiltrate into the surrounding tissue, to destroy the surrounding tissue and to store metastasis to the regional lymph nodes and distant lymph nodes, the malignant tumors are obviously cancerous in nature. Whereas the benign are just a proliferation or outgrowth, and basically they are non-cancerous. So we'll study the tumors involving the arising from the bone, that is the odontogenic tumors arising from the because of abnormalities in the epithelium, there is the any epithelium. Here we'll be studying with the odontogenic epithelium, or tumors arising because of some abnormality in the connective tissue. There is benign and malignant tumors of epithelial tissue origin, benign and malignant tumors of connective tissue origin, benign and malignant tumors of muscle origin or nerve tissue origin. Okay. As a dentist or oral pathologist, we are specifically bothered, or we care about the teeth and the surrounding jaws. So the odontogenic epithelium or the odontogenic tumors are more of a concern to us. We know that developing enamel organ is there. From that, it gives rise to the dentinal tissues, the enamel tissues, and the cementum. So any abnormality during the embryonic development leads to cancerous growth or a benign growth in that particular region, or because of abnormality in the enamel organ. Okay, so the odontogenic tumors are nothing but tumors which are arising from abnormality either in the odontogenic epithelium or in the odontogenic ectomesenchyme. Okay, odontogenic is nothing but the arising from bone. The term, it denotes arising from bone. And as we know, enamel organ or the dental lamina, it differentiates into the enamel organ, and from enamel the tissues, the hard tissues, that is the enamel and dentin, arise. Okay, so we'll study the benign tumors and the malignant tumors. First we'll study the WHO classification of odontogenic tumors. Okay, they are basically divided into benign and malignant. As I always keep telling, benign are tumors which are non-cancerous, and they are always denoted the terms as odontomas, whereas the malignant are the ones which show definite cancerous growth, and they are given the term carcinomas in anywhere, either in odontogenic region or in epithelium or mesenchyme, anywhere. Benign are called as odontoma and malignant are called as carcinomas. Okay. Now the benign odontogenic tumors, they are basically classified based on from where they are arising. If the tumors are arising only from the odontogenic epithelium, if the tumors are arising from odontogenic epithelium and mesenchyme both, or if the tumors are arising only from the odontogenic mesenchyme. Okay. The type 1 benign odontogenic tumors include the tumors arising from odontogenic epithelium only without involvement of the odontogenic ectomesenchyme. Okay. They include the ameloblastoma, the commonest odontogenic tumor, the commonest benign odontogenic tumor. It has very characteristic features, and that despite being a benign tumor, it shows extensive tendency to infiltrate the adjacent bone, surrounding tissues, and has devastating effects. We'll study about detail about ameloblastoma. Then we have squamous odontogenic tumor, calcifying epithelial odontogenic tumor, also known as the Pinbock tumor, and the adenomatoid odontogenic tumor, also known as the adenoameloblastoma. So these four are the tumors arising from odontogenic epithelium where there is no involvement of the connective tissue mesenchyme. Type 2 tumors are those which involve the odontogenic epithelium and with odontogenic ectomesenchyme, but there is no formation of any hard tissue like the enamel or dentin. These include the ameloblastic fibroma, ameloblastic fibrodentinoma, ameloblastic fibroodontoma, odontoameloblastoma, calcifying odontogenic cyst. We have already studied about calcifying odontogenic cyst in the cysts of oral and maxillofacial region. Basically, this neoplasm, it's also known as dentinogenic ghost cell tumor. It has the calcifying odontogenic cyst. It has both variants. There is the neoplastic variant and the cystic variant. Here we'll be studying about the neoplastic variant. Then we have complex odontoma and a compound odontoma. So these are tumors which have involve the odontogenic epithelium with mesenchyme. Okay. Type 3 are the tumors which involve odontogenic ectomesenchyme as well as epithelium, but without epithelium. Okay, these type 3 tumors exclusively they involve the odontogenic ectomesenchyme only. They include the odontogenic fibroma, the myxoma, and the cementoblastoma. Okay. Then malignant tumors is always still malignant denotes the term carcinomatous. Okay, they are divided as type 1 odontogenic carcinomas. It is the malignant ameloblastoma. Ameloblastoma almost always it is a benign neoplasm. Very rarely it shows the carcinomatous form. That is nothing but the malignant ameloblastoma. Primary intraosseous carcinoma, clear cell intraosseous carcinoma, and a ghost cell odontogenic carcinoma. Then sarcomatous form. Sarcomatous forms are a little bit more dangerous when compared to the odontomas. They include the ameloblastic fibrosarcoma, ameloblastic fibrodentinosarcoma, and ameloblastic fibroodontosarcoma. So we'll be studying the most important odontogenic tumors which we'll encounter and commonly which are more of a concern to the dentist because of their characteristic clinical presentations. Okay, ameloblastoma. Ameloblastoma, it is a benign neoplasm. Despite being benign, it shows the characteristic clinical presentation of extensive growth of the tissues, proliferation of the tissues, which is very devastating. And another characteristic of ameloblastoma is that it just tends to spread and involve the bone and the adjacent, infiltrate the adjacent tissues. Okay, despite being a benign outgrowth, it appears that it is metastasizing or it is spreading very rapidly. It is invasive in nature. So it gives a clinical picture of invasion because of its expanding capacity. Okay. Basically, there is a characteristic definition given for ameloblastoma. That is, the tumor is unicentric, non-functional, intermittent in growth, clinically benign, anatomically benign, and it is a clinically persistent lesion. As I told you, it's a benign lesion but with proliferative growth. It is unicentric, means that it's arising only from a single center. Like say here, the most common variety for giving rise to ameloblastoma is the enamel organ type tissue. As the name itself indicates, ameloblastoma, it's something that there is a tumor is involving the ameloblast or the ameloblast like cells. Okay, so it's a true enamel organ type tissue, and pathogenesis for giving rise to ameloblastoma is the involvement of the cell rests of dental lamina or the developing enamel organ or from the epithelial lining of odontogenic cyst. So all these are the contributory factors which give rise to cells which just proliferate, either the epithelial rests of dental lamina, they just proliferate and lead to outgrowth of the tissues. So here you can see the characteristic clinical appearance of the ameloblastoma. More commonly, this ameloblastoma involves the mandibular ramus area than the maxilla. About 75% cases involve just the mandible. Okay, here you can see this involving the mandibular ramus area, and the growth is very extensive. And yeah, the ameloblastomatous growth, it is a very slow growing one, but an expanding lesion. Okay, we'll see the characteristic clinical features of ameloblastoma. Basically, ameloblastoma have been divided into 3 different patterns. There is the conventional solid or unicystic pattern, multicystic pattern, unicystic pattern, and a peripheral or extraosseous form. We'll see each of one in detail with the characteristic clinical features, the radiological features, the histological features. and the treatment aspect. And the diagnostic feature for ameloblastoma is that because of its extending expansile nature, what happens is the buccal and the lingual cortical plates, both of them expand. And since this is a slow growing lesion, it allows for the buccal cortical plates to develop a thin layer of cortex over the lesion. So whenever you are just palpating the lesion, whenever you are suspecting the case of ameloblastoma, when you palpate the lesion, you heard the characteristic eggshell cracking sound. That is because of the thin layer of cortex surrounding the lesion. And this thin layer of cortex develops only because of the slow growing nature of this lesion. So the diagnostic feature of ameloblastoma is the eggshell cracking sound. Okay. So the conventional solid or multicystic intraosseous ameloblastoma. Intraosseous is nothing but it is arising within the bone, from within the bone. So it has been seen through a wide age range. It is seen, the solid or multicystic forms are seen from about 10 years of age to 90 years, to wide age range. There is no sex predilection. Both the genders, both the males and females are just affected equally. And as I told you, ameloblastoma, about 80 to 85% cases are seen in the mandibular ramus area. This is basically a benign lesion, right? So it takes on months or decades to develop, and it is a very slow growing lesion. Clinically, it is asymptomatic. Visible swelling is seen when the lesion is very expanding in nature, and both the buccal and the lingual cortical plates are just expanded. So appearance of swelling is the only characteristic feature. Pain is of late in origin. Okay. When the lesions are very small, they are just detected during routine radiographic examination only. But when they are like little bit larger lesions, because of the swelling, characteristic swelling, they may be manifested. Okay. And the swelling is usually painless. The characteristic, these were the characteristic clinical features of the ameloblastoma, intraosseous one. Okay. Now as I told you, the radiological features are also diagnostic. The multicystic pattern, it presents as a unilocular radiolucency or a multilocular radiolucency, right? The multilocular radiolucency, it gives the appearance of a soap bubble or a honeycomb pattern. So that is the characteristic feature of the ameloblastoma. Okay, the appearance of soap bubble or honeycomb pattern. And both the buccal and lingual cortical plates are expanded, and whenever the tumor is involving the mandibular ramus area, if suppose the teeth are involved in that particular region, there is a resorption of roots of that teeth, and along with that obvious mobility of teeth will be there, and the margins of bone or the margins of teeth or the alveolar bone, they show some form of irregular scalloping, and sometimes this lesion also may be presented as a unilocular radiolucent lesion. If we see there is a CT scan of the person, and it's on the left side, towards the left side is just showing a unilocular radiolucent lesion with some scalloping, some marginal scalloping of the alveolar bone, giving the appearance of a honeycomb pattern. Okay. Now the microscopic pictures of ameloblastoma are very characteristic because they show different patterns of appearance. Or the epithelial component and the mesenchymal component both will be present, but they show the characteristic pattern. The arrangement is little bit different. Based on their arrangement, it is divided into follicular, plexiform, acanthomatous, granular, desmoplastic, and the basal cell type. So we'll study what each one, how the epithelium is arranged in each of these lesions. And the name ameloblastoma, so the cells, the tumor cells, whatever we are seeing histologically, they resemble the ameloblast cells. How are the ameloblast cells? The ameloblast cells are nothing but the tall columnar cells with the peripheral palisading and a nuclei which is just situated to one side. That is the characteristic ameloblast cells appearance. So when we see the follicular pattern of solid ameloblastoma, here what happens is the tumor cells, the tumor, it is composed of small islands of odontogenic epithelium. So now if you can see the histologic picture there, if you consider one area, the lower right one area, it is just showing island of tumor cell, If you closely observe the island of tumor cell, the peripheral layer, it shows the presence of the tall columnar cells. These tall columnar cells, they just resemble the ameloblast-like cells. The epithelial cells are peripheral tall columnar cells, but the nuclei is just situated opposite to that of a basement membrane. That is, the nuclei shows the characteristic reverse polarity. Okay, tall columnar cell with reverse polarity peripherally. Now we see, when we see centrally, this the island of tall columnar cells, it encloses a mass of polyhedral cells. These polyhedral cells, they resemble the stellate reticulum. So the peripheral tall columnar cells resemble the ameloblast, and this island is composed of central polyhedral cells resembling the stellate reticulum. So appearance of ameloblast-like cells and stellate reticulum-like cells arranged in islands-like thing is the characteristic pattern of a follicular pattern of ameloblastoma histologically. Reverse polarized nuclei is another characteristic feature. Okay, that's the histologic picture. Now if we see the plexiform pattern also composed of the same odontogenic epithelial cells, that is the peripheral tall columnar cells, but here instead of islands, the epithelium will be just showing a growth which is just interconnected in nature. Okay, it's just expanding or interconnecting in nature. The characteristic fishnet pattern term is given to this because the tumor cells are not divided into islands. In fact, the epithelial cells of all the tumor cells are just connected together, and the same characteristic appearance of ameloblast-like cells, that is the tall columnar cells with reverse polarized nuclei, are seen. Sometimes what happens is the odontogenic epithelium of the tall columnar cells, they appear as a double row of cells because of the close interconnection between the odontogenic epithelium. Okay, and the central cells, they again resemble the stellate reticulum-like cells. Okay, and the stroma, it is just very loosely arranged and it is vascular or hypovascular in nature. So the plexiform pattern, also known as fishnet pattern, similar to the follicular pattern, only difference is the interconnecting strands like odontogenic epithelium. Acanthomatous pattern, here what happens is the cells, we know that there are two, up till now we have clearly understood that there are ameloblast-like cells and there are stellate reticulum-like cells. In acanthomatous pattern, the stellate reticulum-like cells of the follicular pattern, if we see the follicular pattern ameloblastoma, the stellate reticulum-like cells, they just undergo squamous metaplasia, that is, they show the keratin pearl formation. This keratin pearl formation occurs in the region of stellate reticulum, that is the central portion of the follicular ameloblastoma. If squamous metaplasia is seen, then the term acanthomatous type of ameloblastoma is applied. Okay, epithelial or keratin pearls are characteristic here. Now we'll see the granular ameloblastoma. In the stellate reticulum-like cells, some transformation is occurring, leading to the appearance of the this granules within the cytoplasm of the stellate reticulum-like cells. Okay, the stellate reticulum-like cells, they just become very coarse, granular and eosinophilic in appearance. These cells, they have abundant cytoplasm with eosinophilic granules. The stellate reticulum-like cells show the characteristic changes in the granular ameloblastoma. There is appearance of granules-like cell in the cytoplasm. They resemble lysosome ultrastructurally. Okay. The desmoplastic pattern also composed of islands of odontogenic epithelium, which may be arranged in different forms, like they may be arranged in small cords of epithelium or small strands of epithelium which are just compressed by the collagenous stroma. Here the stroma tends to be very dense in nature. Okay, the epithelial proliferation is just compressed by the stroma. So when you see a histologic picture, the characteristically you see wide stroma and very few of the odontogenic epithelium, because the odontogenic epithelium is just compressed and it is not that proliferative in nature. Okay, the central cells, there is the stellate reticulum cells, are very few in number or just scanty, and the peripheral cells, until now they were tall columnar, but here in desmoplastic pattern, instead of being tall columnar, they just become the flat or cuboidal cells. And the basal cell pattern is characteristic in that it bears resemblance to the basal cell carcinoma. The tumor cells, they are arranged in the uniform nest of basaloid cells. Histopathologically, it is similar to the basal cell carcinoma. No stellate reticulum is present. So stellate reticulum initially it was very prominent. Then in the Acanthomatous pattern it is undergoing metaplasia. Then in the desmoplastic pattern it is just becoming scanty, and when it is coming to basal cell pattern there is no stellate reticulum at all, and the peripheral cells, they just become cuboidal in nature rather than being a tall columnar cells. So both the ameloblast like cells and stellate reticulum like cells are characteristic in all the patterns of ameloblastoma, histopathological patterns. Only the variation in their appearance is characteristic of each type. So now we have seen the clinical features, the histological features. So what treatment is given for ameloblastoma? Simple enucleation and curettage were carried out initially, then en bloc resection is carried out. What happens is the ameloblastoma, it is a very expansile in nature. Though being benign, it is expansile, it involves the bone, it involves the surrounding tissues, and it is very invasive, appears to be invasive in nature. It is very slow growing but expansile in nature. So whenever you are carrying out en bloc resection, the adjacent involved bone may have to be excised. So surgical deformities are seen later on, which can be just replaced by compression plates of the mandible and replacement of the structures which are just excised surgically. But the ameloblastoma, it tends to infiltrate between the trabeculae of the adjacent bone involved. Ameloblastoma is an infiltrative tumor, right? So when treating it, you have to just excise about 1 centimeter margin beyond the invasion. Okay, so marginal resection of the mandible involved the bone along with the soft tissue structures is just excised. And though ameloblastoma is a radiosensitive tumor, radiotherapy is not used as the only form of treatment, because sarcomatous changes were seen when radiotherapy was used alone. So surgery is the conventional mode of treatment for ameloblastoma. After surgery, you can just keep the patient if required only under a follow-up, because most recurrences of ameloblastoma are seen within a 5-year period after surgery. So the patient has to be kept under follow-up for about 5 years. So if there is any recurrence of the tumor, then you can undergo radiotherapy and chemotherapy simultaneously. Okay, mostly when you excise the during surgical excision, if you excise the lesion beyond 1 centimeter beyond the margin, there are lesser chances of recurrence. And malignancy in ameloblastoma is very rare. It has been just reported in about 1 or very less than 1% of cases. And sarcomatous changes were observed only when radiotherapy was the form of treatment for ameloblastoma. Okay, so enucleation, curettage, marginal resection involving the mandible and the peripheral ostectomy is the treatment of choice for the solid or multicystic ameloblastoma. Even the unicystic forms as the peripheral ameloblastomas too. Okay, so we have seen the solid variant of ameloblastoma. Now we'll see the cystic variant of ameloblastoma. The name cystic variant itself gives an indication that though it is a tumor, it's giving the appearance of a cyst. Both clinically and radiologically, it's giving the appearance of a cyst. Only when you go for a histological diagnosis, then you can give the final diagnosis of ameloblastoma, because the clinical and radiologic pictures appear to be that of a cyst here. So unicystic ameloblastoma, it is a very less frequently seen ameloblastoma. It is only seen about in 1% of ameloblastomas. It clinically presents in younger aged individuals, mostly above the average age being 23 years of age, and as with all ameloblastoma, it is asymptomatic and a slow growing lesion. It causes a painless swelling of the bone, and the swelling is of very slow growth, so it may take a lot of time for the patient to notice the visible clinical swelling. Okay, when you see the microscopic picture, so young age is the characteristic of this unicystic ameloblastoma. So the clinical pictures of a painless slow growing swelling. Then when you see a radiological picture, it appears as a unilocular circumscribed radiolucency. Sometimes what happens is this radiolucency, it surrounds the crown of an unerupted molar, giving the appearance of a dentigerous cyst like a lesion. Okay, so that's why the name unicystic ameloblastoma has been given. It is a unilocular radiolucent lesion, and sometimes when it surrounds the crown of an unerupted tooth, it gives the appearance of a dentigerous cyst. Okay, that's the microscopic. Let's go to the microscopic diagnosis. When we see the histologic features, the cystic variant, the unilocular cystic variant, it appears in three forms. There is the intraluminal unicystic ameloblastoma, luminal unicystic ameloblastoma, and mural unicystic ameloblastoma. Obvious cyst is present. Okay, cystic lining is present here. Surrounding this cyst wall, the odontogenic epithelial lining or the ameloblastomatous epithelial lining will be present. Okay, so luminal unicystic ameloblastoma, here what happens is the microscopic picture gives an appearance that the tumor is just attached to the cystic wall. Okay, so the cyst, one side there is a fibrous cyst wall with a lining that consists of the odontogenic epithelium. The other side is showing a basal layer of columnar or cuboidal cell. Again, these columnar cells, they show hyperchromatic nuclei and show the characteristic reverse polarization as seen in the tall columnar cells of the solid variant of ameloblastomas. Okay, so one side only the cystic wall is present, which is lined by the odontogenic epithelium or the ameloblastic epithelium. Okay, this ameloblastic epithelium again has characteristic tall columnar cells only, and the cells, they show central vacuolation, that is the cytoplasm appears to be vacuolated or empty, and the epithelial cells present in the cystic wall or the fibrous cyst wall, they appear to resemble the stellate reticulum like cells. So again, the characteristic appearances of ameloblast like cells and stellate reticulum cells is diagnostic here. But only the thing is, there is appearing to be a cystic lining or the cystic wall is present. Intraluminal unicystic ameloblastoma, here what happens is the tumor shows that one or more nodules of ameloblastoma, they just project into the cystic lumen. So luminal was the tumor or the ameloblastoma's epithelium, it is just attached to the cyst wall. Here intraluminal is the tumor is just entering the cystic lumen. So cystic lumen is present and tumor is present within the cystic lumen. Okay, nodules of ameloblastoma may be present. They just fill the cystic lumen. So one big cyst is present. In the lumen of the cyst, you get to see the nodules of ameloblastoma like tumor cells, ameloblast like tumor cells. Okay, and this tumor cells, whatever are present, they present the characteristic plexiform pattern of ameloblastoma, as we have already seen in the solid ameloblastomas. Okay, there is interconnecting strands of epithelial cells. Along with that, centrally you see stellate reticulum like cells. Fishnet pattern characteristic of that. Okay, mural unicystic ameloblastoma, here again the cystic lining is present, but it is infiltrated with the follicular type of ameloblastoma. Follicular type of ameloblastoma is nothing but islands of tumor cells seen with the peripheral tall columnar cells and central polyhedral cells, that is a stellate reticulum like cells. Okay, just within the fibrous cyst wall, all these tumor islands are present. The treatment for this unicystic ameloblastoma is nothing but cystic enucleation. So the cysts, they show a tendency to recurrence because of their infiltrating nature, because of their presence of this proliferating epithelium. If the remnants of cyst wall are present, again they may lead to recurrence of the cyst. Treatment is nothing but enucleation only. Okay. Now we'll see the peripheral ameloblastoma. Peripheral ameloblastoma, it's also known as the extraosseous ameloblastoma. It's nothing but it is seen within the soft tissues of the oral cavity. Okay, most commonly the gingiva shows this form. So it is a very uncommon tumor, and only about 1% of all the ameloblastomas shows the peripheral or extraosseous ameloblastoma. Etiology is nothing but it arises from the rest of dental lamina or from the rest of basal epithelial cells. And clinically it presents as a painless, again it is painless, very slow growing, it is non-ulcerated, sessile or pedunculated tumor mass which appears to be fibromatous in nature clinically, because it is just seen as a nodule on the gingiva or the alveolar mucosa. Okay, sometimes when the nodule is a little bit excessive, it shows the superficial erosion of the alveolar bone. It is typically seen in middle-aged individual, that is about 25 years of age, about 25 to 30 years of age. You see this peripheral ameloblastoma. When you see the clinical features, they are non-specific in nature. They will just represent the appearance of a nodule on the gingival mucosa. So it may be a fibroma. Clinical, there is no relation between the clinical features and the appearance of this peripheral ameloblastoma. So the extra-ossous ameloblastoma, it just represents either a fibroma or a non-specific granuloma. Okay, when you see the histologic picture, only that is diagnostic. Even the radiologic picture is not diagnostic, because it's just showing a superficial erosion of the alveolar bone. So histologically, again, you get to see the characteristic islands of ameloblastic epithelium. That is the appearance of a tall columnar cells, ameloblast-like cells with reverse polarity. And the proliferating epithelium, it shows the pattern of either the plexiform pattern or the follicular pattern, as we have seen in the solid ameloblastomas. So the treatment for any form of ameloblastoma seems to be either a simple enucleation, surgical excision, or marginal resection or en bloc resection involving all of the soft tissues and the bone involving that particular region or space. Okay. Radiation therapy is not recommended for ameloblastomas. So we have seen the most commonest benign neoplasm, that is the ameloblastoma, but it is such of invasive nature that proper care has to be taken to avoid any chances of recurrence. More than the 1 centimeter of margin should be excised when treating it surgically. Okay, now we'll see the other lesions, other odontogenic tumors. There is the calcifying epithelial odontogenic tumor. It's also known as a pinbock tumor. It is a very uncommon lesion. It is a benign tumor again. It is a benign neoplasm that is exclusively epithelial in origin. That is, it is arising from either the rest of dental lamina only. So it involves only the odontogenic epithelium, and this pinbock tumor accounts for less than 1% of tumors. So we'll see what are the characteristic clinical features. The clinical features for this pinbock tumor is that it appears in about middle age individuals. There is about 30 years of age, the mean age being 40 years, and there is no sex predilection, so it occurs both equally in both males and females. And again, as with odontogenic tumors, there is a predilection for occurrence in the mandible, most commonly the molar region, the ramus region. Okay, and clinically this pinbock tumor being benign, it presents as a painless, asymptomatic, slow growing lesion or a swelling, and most commonly seen in the lower jaw. So painless, asymptomatic and slow growing, again giving the similarities between the ameloblastoma and calcifying epithelial odontogenic tumor. When you see the microscope radiologic picture is different. Here it may be presenting as a unilocular lesion, okay, one form, that is a diffuse unilocular radiolucency may be seen, or it may show a combined pattern of radiolucency and radiopacity, that is mixed radiolucent radiopaque lesion, which in that the central radiolucency, it shows some fine bony trabeculae within it, giving the appearance of a multilocular or honeycomb appearance. And within this radiolucency, whatever the flecks of radiopacities are present, they give this appearance of a driven snow appearance. Okay, so the radiologic picture here is diagnostic, and it is different from the ameloblastomas. That is the characteristic opaque calcification are seen, that is the snow driven appearance, and mixed radiolucent radiopaque pattern and only radiolucencies. And when you see the microscopic picture, histologic picture is also diagnostic, as the tumor, it is composed of polyhedral epithelial cells, that is the epithelial cells which are just polyhedral in nature. They may be arranged in different forms, like they may be arranged in sheets, or they may be just scattered tumor cells, islands of tumor cells may be seen, or sheets of tumor cells may be seen, or cords of tumor cells may be seen. And the connective tissue is essentially fibrous in nature. So how are the tumor cells? The tumor cells are with a well-defined border. They have a prominent nuclei, and the intercellular bridges are also very prominent. And the cytoplasm, it shows finely granular eosinophilic cytoplasm. Okay. So the epithelial islands, that is the tumor cells, are arranged in cords or sheets or islands, and the cells are very prominent with a well-defined cell border, the characteristic of tumor cells. The nuclei, frequently it is a pleomorphic, and it shows hyperchromatism also, and gained cells, that is the gained multinucleated cells, are more common here. And other characteristic appearance of this calcifying epithelial odontogenic tumor is the appearance of a eosinophilic hyaline substance within the connective tissue, that is nothing but the amyloid. Amyloid is a pigmented substance actually. Okay, it is a homogeneous eosinophilic substance present within the connective tissue. Amyloid actually cannot be demonstrated by hematoxylin and eosin staining. It can be demonstrated only by the Congo red staining, because it shows apple green birefringence. Okay. Appearance of amyloid and appearance of Lees gang rings. Lees gang ring is nothing but there are some concentric rings of calcifications are seen around the epithelial cells, which are arranged in circular layers. So areas of calcification which are concentric in nature are given the term Lees gang rings. Okay. So the characteristic of calcifying epithelial odontogenic tumor is amyloid, Lees gangrines, and radiologically snow-driven appearance along with the multilocular or honeycomb pattern. Treatment for calcifying epithelial odontogenic tumor is conservative treatment. There is a local excision, and the tumor rarely it metastasizes, or the very few chances of recurrences are seen. Curettage being the simplest form of treatment for this lesion. Because it is a benign one, there are very few chances of recurrence. Now we'll see the other odontogenic tumor, that is the adenomatoid odontogenic tumor. Adenomatoid odontogenic tumor, also known as Adenomatoblastoma, it is a very uncommon lesion. It is a benign neoplasm. Again, it is exclusively epithelial in origin. Only about 3 to 7% of all odontogenic tumors are of this variety. There is the adenomatoid odontogenic tumor. The mean age and the more common characteristic is that up till now either the ameloblastoma or the calcifying epithelial odontogenic tumor, they had a predilection for occurrence in mandible region. That is, the lower jaw was more commonly affected. But the adenomatoid odontogenic tumor has a predilection for occurrence in maxilla. Most commonly, the adenomatoid odontogenic tumor is associated with the unerupted maxillary cuspid. And the mean age for occurrence of adenomatoid odontogenic tumor is about 18 years, and there was a predilection for occurrence in females, and obviously a predilection for maxilla, that too unerupted maxillary cuspid. So clinically they present as very small lesions, that is the sessile masses on the facial gingiva. Just like nodules or like lesion, they may be sessile or sometimes pedunculated. And so the clinically you get to see there is a swelling over the unerupted maxillary cuspid region, and it is not eroding the bone, it is not infiltrating in nature, it is not causing any buccal or lingual cortical plate expansion like that. Okay, and it is asymptomatic, entirely asymptomatic, detected only during the radiographic examination. So what happens during radiographic examination? You see that there is a unerupted maxillary cuspid present. And there are two forms of this adenomatoid odontogenic tumor. One which is arising, which is located essentially around the unerupted tooth. That is nothing but the follicular type. So radiologically it presents as a unilocular radiolucency surrounding the crown of a unerupted maxillary cuspid, follicular type. So it's a unilocular radiolucency, but sometimes it shows radio-opaque foci of calcification here and there within the radiolucency, giving a characteristic snow-driven appearance. And the other type of radiolucency is a unilocular radiolucency, but it doesn't surround the unerupted tooth. Instead, it appears between the roots of two teeth. Okay, the roots of two teeth, you get to see a unilocular radiolucency. That is the extrafollicular type of adenomatoid odontogenic tumor. So that was the characteristic radiologic picture. Now we'll see the microscopic picture. As I told you, microscopic picture of adenomatoid odontogenic tumor, there is epithelial proliferation. But how? The epithelial proliferation of the spindle cells, the columnar cells or cuboidal cells is seen. They are just scattered in a duct-like structures. Okay, circular duct-like structures are present. The duct-like structures, they are frequently lined by a layer of eosinophilic ring, that is nothing but the hyaline ring. Okay. The ductal lumina, the inner side of the duct, it is lined by a single layer of endothelial cells. So the epithelial proliferation is present in the form of duct-like structures. Sometimes some irregular or round calcified bodies are seen within this concentric ring-like pattern, that is a duct-like structure. Within these bodies, here and there you see some concentric calcified bodies. Those are given the terms Lees-Gang ring. So calcification in the form of Lees-Gang rings is also present. So the treatment for adenomatoid odontogenic tumor is nothing but surgical excision or enucleation or curative. Because it is a benign neoplasm, there are less chances for metastasis and lesser recurrence cases. Okay. Now we'll see the squamous odontogenic tumor. Squamous odontogenic tumor, it is also a benign odontogenic tumor. The etiology for epithelial proliferation is the rests of molasses. The rests of molasses are nothing but epithelial rest cells found within the periodontal ligament. Okay. So the source for epithelial proliferation are these rests of molasses. Again, it is a benign odontogenic neoplasm. The clinical features being males are more commonly affected and it is seen over a wide age range. Again, from 10 years to 67 years of age. The clinical presentation, it shows a predilation for occurrence again in the bicuspid molar area, most commonly the mandibular molar area, and initially it begins as it is very asymptomatic, very slow growing lesion, and the clinical presentations may be the mobility of the involved tooth present in the area may be mobile, they may be tender to percussion, and they may be loose or exfoliated, and the clinical symptoms are non-specific. When you see the radiologic picture, it appears as a unilocular radiolucency or semicircular or triangular radiolucency between the roots of a tooth without or any sclerotic border. There is no sclerosis of the surrounding periphery of the radiolucency. Okay, just a semicircular or triangular unilocular radiolucency is seen. Now when you see the microscopic picture of squamous odontogenic tumor, it shows islands of matured squamous epithelium. The mature squamous epithelium is present in the tumor cells. Essentially, it shows the squamous epithelium in that islands of tumor cells. The peripheral layer, instead of being tall columnar, it is just flattened, and the squamous cells, they are very normal to the epithelial cells, but they do not show any pleomorphism. There is no nuclear hyperchromatism because the squamous cells undergo metaplasia. Keratin formation is seen, and along with the epithelium, the connective tissue, it just shows the presence of fibrous collagenous tissue. There is the fibroblast just predominate, and bundles of collagen fibers are seen. Treatment for squamous odontogenic tumor, again it being a benign odontogenic neoplasm, just surgical resection, enucleation or curettage is sufficient. There are lesser chances of recurrence for squamous odontogenic tumor, it being a benign, that is non-cancerous growth. So now we have seen the odontogenic tumor involving only the odontogenic epithelium. So now we'll see the odontogenic tumors which arise from odontogenic epithelium with involving the odontogenic ectomesenchyme also, but without any hard tissue formation. There is no differentiation of the tumor cells into enamel or dentine like that. Okay. Ameloblastic fibroma, as the name itself indicate that there is a combination of presence of ameloblastoma and the fibroma. So we can see the features of both ameloblastoma and the fibroma. We'll see how in detail. So here this tumor, it is an uncommon tumor, it is benign. Again, it is arising because of proliferation of both the epithelial component and the mesenchymal component, but without any enamel or hard tissue formation. There is a predilection for occurrence of ameloblastic fibroma in the mandible, and fibroma is more commonly seen in younger individuals or middle-aged adults, and predilection for males. The tumor shows a slower clinical growth. Initially it is asymptomatic, and being fibroma, it just appears as a swelling on the swelling clinically, and it is a benign one. It does not show any tendency to infiltrate between the bony trabeculae. Ameloblastoma has a tendency to infiltrate between bony trabeculae. It was invasive, but this ameloblastic fibroma, it is just involving the fibrous component more commonly, so it does not involve infiltration. So because of gradual expansion, radiologically it appears as a unilocular radiolucency with a smooth border. So clinically it is asymptomatic swelling on the jaw. Initially it begins as a painless lesion. Again, after some period of time, there is pain, tenderness, and a mild swelling of the involved jaw. Okay, radiologically, sometimes a multilocular radiolucent lesion is seen. Maximum of the time it is just a unilocular radiolucent lesion with a smooth outline and a sclerotic border. Because of gradual expansion, it is having a smooth outline. When you see the microscopic picture of ameloblastic fibroma, both now we have two components. There is the epithelial component, which is essentially denoting the ameloblastomatic epithelium. Mesenchymal component, which is denoting the fibromatous, there is a fibroma or fibromatous component. Okay, how is the epithelial component? Here, epithelial component is just showing the scattered islands of epithelial cells, which are arranged. These islands are arranged in the form of rosettes or ring-like structures or long finger-like strands. So how are the epithelial cells? As the ameloblastic epithelial cells, they are just columnar or cuboidal in nature, and tall columnar, cuboidal with a reverse polarity. Only the feature is that the stellate reticulum is not seen in ameloblastic fibroma. Okay, that is the difference between ameloblastoma and ameloblastic fibroma. And when you see the mesenchymal component, the mesenchymal component, it shows presence of delicate intertwining fibrils. The fibrillar component is present, which is interspersed with the connective tissue cells. Thus it resembles the dental papilla. So appearance of fibrils is characteristic of the mesenchymal component. Sometimes there is a hyalinization of the connective tissue. Okay, so that's about the ameloblastic fibroma. Now we'll see the ameloblastic fibroodontoma. Ameloblastic fibroodontoma, it is basically a benign odontogenic neoplasm which is arising both from the epithelium and the involving the connective tissue, but without any hard tissue formation. It is basically showing features of ameloblastic fibroma and complex odontoma. So what is complex odontoma? Odontoma, it is also a odontogenic tumor, but which is showing the deposition of some calcified tissues. Okay, so we'll study about complex odontoma later on, but we should just remember that ameloblastic fibroodontoma, it is a combination of ameloblastic fibroma and a complex odontoma. It is basically associated with unerupted or impacted tooth. More commonly, it is seen in children within the ages of 10 years, and maxilla and mandible both are affected with equal frequency. So the one which is seen in younger individuals is the ameloblastic fibroodontoma. Initially it begins as a painless asymptomatic lesion, then it expands very slowly and there is no infiltration of the bony trabeculae seen. And radiologically it just presents as a well circumscribed unilocular radiolucency, which is expansile in nature, which is smooth in outline. Sometimes within this unilocular radiolucency, small radio opacities are seen representing the odontoma. Okay, odontoma is nothing but a calcified tissue. When you see the microscopic picture of ameloblastic fibroodontoma, epithelium is seen. Again, the ameloblastic epithelium arranged in the form of cords or sheets or rosette like long figure like strands are seen, which is having odontogenic cuboidal epithelial cells. Again, the mesenchymal connective tissue, that is the fibrous connective tissue, is seen, which is interspersed with many delicate intertwining fibrils, and presence of fibroblasts is characteristic here. And occurrence of opacities, there is a typical composite odontoma appears, there is a calcified tissue is seen. This calcified tissue, it bears resemblance or similarity to normal tooth structure, that is the enamel and dentin appearance in the calcified tissue is seen. So the microscopic picture, essentially a picture of ameloblastic fibroma along with the typical composite odontoma and amel and dentin formation is seen. So that was about the ameloblastic fibroodontoma. We have seen ameloblastic fibroma, ameloblastic fibroodontoma. Now we'll see what is odontoma. Odontoma is nothing but a tumor which is arising because of both the epithelial proliferation and the mesenchymal connective tissue proliferation. Here the cells, they just differentiate and form into some calcified tissue which resemble the enamel and dentin formation. Okay, so they represent the hematomatous malformation. They are just tumor-like lesions which resemble similarity to enamel or dentin. Odontomas are basically the calcified tissues bearing resemblance to the they may bear resemblance to normal tooth structure, or they may not bear resemblance to normal tooth structure. Based on that, they are divided into compound composite odontoma and complex composite odontoma. Compound composite odontoma. Here, whatever the tumor-like depositions or calcified structures are deposited, they are arranged in just concentric layers and they resemble the normal enamel and dentin seen in the teeth, and thus they bear a morphologic resemblance to the normal teeth structure. Those are nothing but the compound composite odontoma. Whereas the complex composite odontoma, here the calcified dental tissues are deposited, but they are deposited in an irregular mass, so they bear no morphologic similarity to the teeth, anatomic teeth. So the clinical features of odontoma is that it occurs in very young aged individuals, about 18 years of age. There is no sex predilection. Sometimes males are more commonly affected. Maxilla is more commonly involved, and whatever the calcified tissue is deposited, it is very small in diameter, and the diameter does not exceed the diameter of a tooth, and it is asymptomatic in nature. It is just detected on radiographic examination only. Clinically, it is asymptomatic. So when you see the radiographic picture, it shows that some calcified mass is present between the roots of the teeth. The irregular calcified mass is just surrounded by a narrow radiolucent band. Sometimes tooth-like or cusp-like structures may be seen between the roots of teeth. So when you see the microscopic picture of odontoma, here you can see that there is a disordered mixture of dental tissues. There is the calcified tissues are present here and there. They may resemble the normal enamel, dentin and pulp tissue, but the relation between enamel, dentin and pulp to one another is not normal. They are just disorderly organized, and the connective tissue is just resembling a follicle surrounding an erupting tooth. So just you can see in the histologic picture that calcified deposits are seen here and there, and they are just disorderly organized. When you just study them histologically, they bear a resemblance to normal enamel, dentin and pulp. Ameloblastic odontoma, as the name itself suggests, it is also known as odontoameloblastoma. It actually represents two separate neoplasms growing in unison. That is, it has a mixture of ameloblastoma and odontoma. We have seen ameloblastoma. It is a benign neoplasm, odontogenic neoplasm arising from epithelium or the cell rests of lamina. Whereas the odontoma, it is just a hematomatous proliferation resembling deposition of calcified tissue resembling the enamel and dentin. So combination of both these is the odontoameloblastoma. Odontoameloblastoma, basically they occur at any age. There is no particular age at which they are seen more commonly. It affects wide age range from children to young to elderly, and it is seen more commonly in males, and posterior mandible is more commonly affected. So initially it presents as a slow growing lesions. All ameloblastoma lesions are slow growing lesions only. Initially they begin as asymptomatic painless swellings only. So once they just grow to a considerable size, they lead to expansion of the cortical plates of the bone with considerable facial swelling and facial deformity. As the lesion progresses with cortical expansion, it shows mild pain and tenderness to percussion of the involved teeth, and the teeth may not erupt also. This delayed eruption of teeth. When you see my radiologic picture, because of the expansion of the cortical plates, there is just destruction of the cortical plates at a later stage, and numerous small radiopaque masses may be seen Within this radiolucent lesion, numerous small radiopaque masses are seen. They may or may not bear resemblance to the normal teeth. That is, calcified structures are seen radiographically. So when you study this picture histologically, you see that the structures, that is the calcified structures, whatever are present, they resemble the normal tooth germ or the atypical tooth germ. There is enamel, dentin, tissues are present but disorderly organized, and when you see the epithelial component, it is again showing the same features as the ameloblastoma epithelium. There is the columnar, cuboidal or squamous epithelial cells which are arranged in different patterns. So the microscopic picture shows the ameloblastic epithelium, keratin pearls, enamel, dentin, and the sheets of atypical ameloblasts. That is, the calcified structures resemble enamel and dentin, right? So ameloblastic epithelial components along with this odontoma components, that is the enamel and dentin, is seen. So that was about ameloblastic odontoma. Calcifying odontogenic cyst or dentinogenic ghost cell tumor. As we have already studied about the calcifying odontogenic cyst in detail in the cysts of oral and maxillofacial region. That was the cystic variant. Now we will study the neoplastic variant or the tumorous variant. The calcifying odontogenic cyst is also known as the dentinogenic ghost cell tumor or Gorlin gold cyst. It was there were a lot of the theories proposing that it was a cyst, and few of the authors just argued that it was a tumor. And later on, there were two precarious et al. He gave that no, there are two variants. One is the cystic variant, one is the neoplastic variant. The neoplastic variant, it may show just three patterns of variation. There is a unicystic variant or ameloblastomatous type variant and a proliferative variant of calcifying odontogenic cyst. Okay, so the neoplastic lesion, it basically accounts for just about the 1% of all the intraoral odontogenic tumor, and it is very uncommon lesion. It basically presents in middle-aged individuals about 20 to 30 years of age, and it has predilection, no gender predilection, and it has two forms. There is the intraosseous form and the extraosseous form. Initially, it begins as a painless lesion, but it is expansile nature. Once it just expands the cortical plates of bone, symptoms of early pain and involvement of the adjacent teeth, mobility and tenderness to percussion may be seen. It just presents as a nodule on the mucosa. So when you see the radiologic picture, it essentially it's of a expansile lesion, that is a unilocular radiolucent lesion is seen. Sometimes radiolucency may be seen with occasional flecks of calcification here and there, or radiopacities within the radiolucencies. Okay, snow-driven appearance, that is also seen here. So the histologic picture is the only diagnostic picture of calcifying odontogenic cyst. Histologic picture, when you see the cystic variant, you see that the cystic variant is just divided into 3 or 4 types based on the proliferative lining epithelium. Okay, the proliferative lining epithelium may be keratinized or may not be keratinized, or based on that it is just divided into 4 types. But here the neoplastic variant, you see that the characteristic islands of odontogenic epithelium are present, and these odontogenic epithelium, they show the peripheral layer of columnar cells which are just palisaded with hyperchromatic nuclei, and within this peripheral layer, islands of cells are present. Peripherally columnar cells are present. Centrally there are stellate reticulum like cells, thus resembling the ameloblastoma cells. Within this central stellate reticulum like cells, few of the cells, they just undergo keratinization, giving the appearance of a ghost cells or empty cells when observed under H&E staining. Okay, so then hence the name ghost cells has been given. The stellate reticulum cells undergo keratinization. So histologic picture or occurrence of ghost cell keratinization is characteristic of calcifying odontogenic cyst. So we have seen all the benign odontogenic tumors. Odontogenic tumors, ameloblastomas, ameloblastic odontomas, calcifying odontogenic cyst, we have seen all those. Both involving the odontogenic epithelium, odontogenic ectomesenchyme, and only the ectogenic odontogenic ectomesenchyme. Now we'll see the odontogenic carcinomas. Again, odontogenic carcinomas may be divided into 2 forms, that is the odontogenic sarcomas and the odontogenic carcinomas. Sarcomatous form are basically seen in cases where there is changes within the existing neoplasm. There is ameloblastic fibrosarcoma, odontogenic fibrosarcoma, like that. So we'll see the carcinomatous form first. The malignant ameloblastic carcinoma. It is very rare, very uncommon lesion. The ameloblastic carcinomas, rarely they metastasize or rarely they become malignant. Sometimes it is just reported to be 0.5 to 1% cases of ameloblastoma being transformed into a malignant carcinoma. So when there is the epithelial proliferation undergoes malignancy, it's known as a carcinoma ex ameloblastoma. Ameloblastoma, malignant ameloblastoma may also arise de novo, that is newly from the proliferation of epithelial lining, that is the cell rest of dental lamina, giving rise to the term de novo ameloblastic carcinoma. So here the ameloblastic cells are present, ameloblast-like cells are present, islands of odontogenic epithelium is present, stellate reticulum-like cells are present, but the peripheral tall columnar cells with reverse polarization, whatever are present, there is loss of reverse polarization here. There is greater cytological atypia, there is mitotic activity is excessive, there is all dysplastic features may be seen, that is increase in nuclear cytoplasmic ratio, increase in nucleolus, loss of polarity of cells, loss of reverse polarization, and disturbance between the number of cells and the number of nuclei may be present. So it is an aggressive neoplasm, it is locally invasive and it just metastasizes to the regional lymph node. Normally only ameloblastoma, it is though being benign, it just infiltrates the bony trabeculae. When it gets these malignant features, it becomes more invasive in nature and it just spreads to the lungs, the regional lymph nodes and other parts of the body. Carcinoma ex ameloblastoma is malignant change which arises when ameloblastoma, benign neoplasm ameloblastoma, it undergoes differentiation because the epithelial cells, they show excessive mitotic activity, they show dysplastic changes that leads to carcinomatous changes here. Initially what happens is most of the time follicular pattern of ameloblastoma, that is the islands of epithelial cells with central stellate reticulum like cells, or the interconnecting strands of ameloblastic odontogenic epithelium, there is the plexiform variant, they undergo this hypercellularity. There is an increase in cell, increase in number of nuclei, loss of polarity, and they just develop into the poorly differentiated carcinoma. Carcinomatous cells, they show nuclear hyperchromatism. There are changes in the number of cells, number of nuclei, increase in nuclear cytoplasmic ratio, loss of polarity is seen. De novo ameloblastic carcinoma, as I told you, sometimes ameloblastic carcinoma just arises itself without showing any benign lesion. Okay, that is nothing but de novo. Plexiform variant is more common. The epithelial processes, whatever are present in the plexiform pattern, which show the columnar cells, and the central stellate reticulum like cells are seen in the benign neoplasm in this de novo ameloblastic carcinoma. But only thing is there is lack of reverse polarization here when the ameloblastoma arises de novo. So that's about the ameloblastic carcinomas, benign and the malignant. And there are other changes of ameloblastoma in malignancy, that is the ameloblastic sarcomas, which also show the same characteristic features of malignancy. That is, they tend to infiltrate into the adjacent tissues, they just spread to the regional lymph nodes and metastasize.